Thanks, Wendy, and thank you all for being here. It's nice to see some friendly faces that I recognize out there, and then other new faces. And so I have got a bunch of slides. I think some of this may be fairly old hat and intuitive to some of you. For others, it may be some new information, but I really want this to be interactive and engaging, so feel free to just interrupt me with questions if you have questions or if something's not clear. I've tried to be acronym free as much as I can. The first lesson in behavioral health is that we have a language all our own, and so if one slips in and you don't know what it means, just please interrupt me. So as Wendy indicated, I kind of wear two hats right now at the Department of Health, which has actually been really fun because it's gotten me out of just thinking about behavioral health issues, including mental illness and substance abuse. And I've been thinking about a much larger public health perspective, and specifically as it relates to prevention activities, women and children's health, HIV/AIDS, and many other areas within the Department of Health Services. And so it's actually been a really good experience for me. To kind of put together my presentation today, first I pilfered from your website and wanted to kind of make sure that what I wanted to talk about today would still be really relevant to what is of most importance to you. And so we're going to talk about health disparities in a particular population, and that is individuals with serious mental illness. And I would argue that this is a population that tends to be underserved and frequently coming from a lower socioeconomic background. We'll hit on some of the influences, specifically some of the sociocultural influences that influence the health disparity situation that many of these individuals experience. And we're going to talk about health outcomes, but not only from the perspective of substance use and mental health, but also physical health outcomes. And then that's the main issue that I want to kind of drive home. So there was a very important paper published in 2006, and it came from the Medical Directors Council of an association called the National Association of State Mental Health Program Directors. And this is the group of kind of my colleague from every state. Every state has an identified mental health director and an identified substance abuse director. Here in Arizona, it's one and the same. In some other states, the substance abuse agency is completely separated from the mental health agency. In about 30 states now, they're within the same agency or perhaps within the same division as they are in Arizona. But there was a very important paper that came out that really looked at the morbidity and mortality of individuals with serious mental illness. And this really was an eye-opening experience, and you'll see this report referenced in many different situations still today. What they found is that people with serious mental illness that are in the public mental health system die on average 25 years younger than someone without a serious mental illness. Here in Arizona, the research showed that it was closer to 30 to 32 years. And that's just completely unacceptable, no matter how you slice and dice that or try to rationalize it. Some of the recommendations that actually came out of this paper really talk about recognizing individuals with serious mental illness as truly being an at-risk population and recognizing them as a health disparities population in our country. They also called for increased coordination between mental health and general physical health care as a state-level priority. And then they wanted to encourage that there be increased and improved access and integration for physical and behavioral health care. Some of the other things that this report noted was that suicide and injury certainly contribute to mortality for this population. But if you take out the behavioral health problems of these individuals, what you will see is that the majority are actually dying from physical health conditions that are considered natural causes. And we see this. We study every single mortality of individuals that are in the public behavioral health system, And it is not uncommon to see individuals that are dying in their 40s and 50s, and it's a natural cause. I'm not sure what's natural about dying in the 40s of diabetes or respiratory illness, but it happens a lot here in Arizona, and our data suggests that that is consistent not only here but nationally. We also know that individuals who have been diagnosed with schizophrenia, one of the more chronically and severe mental illnesses, are much more likely than the general population to have these kinds of physical health conditions, including diabetes, cardiovascular, respiratory, and other sorts of infectious diseases, that they're anywhere from 2.7 to 3.4 times more likely than the general population to have these same illnesses. And that when you look at the number of deaths, cardiovascular disease is the most common. We also know that tobacco use is a huge problem in not only the behavioral health recipient community, but also behavioral health providers. We know that people that work in the behavioral health field are more likely to smoke cigarettes as well. And I won't go into the whole history of how the tobacco industry specifically marketed tobacco to people in state hospitals, but certainly behavioral health providers have historically used cigarettes as a commodity to reinforce positive behavior, and it's just been we've established a situation in this country that absolutely must be addressed. But we know that up to 88% of people with schizophrenia smoke cigarettes, and we're not just talking about a half a pack. Many of these people smoke 3 to 4 packs a day, and when they smoked cigarettes, in addition to smoking more, they also, and I'm not sure what the term is, but they smoke them down to the butt. They get every last bit of tar and nicotine out of a cigarette. So the exposure is that much worse for individuals with serious mental illness. We also know that smoking can contribute to some of these other sorts of physical conditions. So this, I think, is my last slide for me making my case that this is, in fact, a health disparities population. But we know that at least 75% of adults with serious mental illness have at least one chronic medical condition. We know that these individuals are less likely to receive primary care, screening, prevention activities. They're more likely to have undiagnosed, underdiagnosed, or undertreated physical health conditions. And we know that compared to the general population, they're less likely to engage in healthy lifestyles. They're not as physically active in many cases. Their diets may be less healthy, and that can be for a variety of reasons, including the socioeconomic status and the ability to access healthy foods. Again, we've already talked about the access to medical care. And then there's this whole other side that we've learned more and more recently with many of the medications that are meant to help treat the behavioral health condition can actually lead to pretty significant weight gain. It can contribute to metabolic conditions and pre-diabetes. It can affect cholesterol levels, and also a hormone called prolactin, which could even lead to breast cancer or other sorts of cancers. So these medications, you really have to look at the risks and the benefits for them. And then again, back to the cigarettes, and even today, how many cigarettes are sold to this population. So keeping all of that in mind, we also want to highlight just some of the factors that I think contribute to difficulty in reaching this population, having them routinely and willingly present for care. One of the biggest factors that's getting a lot of attention, and my friend Diane can talk about this, as can others in the room, that there may be a real fear in going to an emergency department, for example, or even going to see a primary care physician. Individuals who have a more severe or chronic mental illness may have experienced significant stigma. They may have felt very unwelcome. They may have had difficulty expressing the symptoms, the physical health symptoms that they were experiencing, and walked out of there with a very bad experience. Individuals who may have presented to an emergency department may have found themselves in restraints, and they have experienced real trauma. And so there is a real focus nationally now on what is called trauma-informed care, meaning that when you're working with someone with a significant behavioral health illness, you need to be aware that they may come from a very traumatic background. They may have been living on the streets at one point. They may have been neglected or abused as a young person. They may have experienced a very upsetting kind of experience in a physical health care setting or hospital. And so that, it's kind of like going to the dentist. I mean, you know, no, you have one bad experience with the dentist and you don't want to go back, and you dread it and you put it off. And that's what often happens when it comes to going in for a routine checkup. And so there are certain factors that have contributed to this lack of access. Certainly homelessness, unemployment, the resources and the finances to be able to pay for medications or to pay for going in to see a physician in some cases. Incarceration in and out of a jail setting can lead to poor coordination of care and losing contact with a treatment team. Certainly social instability and other sorts of factors have put us in a situation where we need to work that much harder to get folks the primary care that they need. As we've already kind of hit on, there's also some provider factors there, and I can attest to this, that in medical school, you know, you're taught kind of a bedside manner in some cases, and some people tend to lose that over time anyway, depending on what you go into. But you're not necessarily taught how to engage, interact, and develop a rapport with somebody who may have some paranoid beliefs, who may have been traumatized, who may be struggling with pretty severe depression and tearfulness. There's not a lot of primary care doctors that, or even other healthcare providers that feel that they have the time or the expertise to really work with somebody who's experiencing those kinds of feelings at that time. And so there are a lot of providers that may not be particularly interested in working with folks with more severe mental illnesses. So attracting a network of providers is one of the things that the Department of Health is about, and certainly many of our universities and institutions and community colleges. We want to attract and train a workforce that not only has the skills needed to treat somebody's diabetes, but also deal with, in real time, other sorts of behavioral health symptoms that someone may be experiencing. And then certainly funding is a challenge. I'm thrilled that one of the things that is part of the healthcare reform legislation is around parity. We are moving into a system finally where health insurers cannot unfairly limit the number of visits you may have with a psychiatrist or a therapist, or institute other sorts of higher copays and things like that because you have a behavioral health illness. So I will move on. I can go on and on about all of that stuff. So when you take all of this into account, it screams that we need to do more around better integrating care to treat the whole person in Arizona. It will really help us not only lengthen the lifespan and improve the health outcomes for individuals, but it will help us overcome these disparities that we've been talking about. This will also, I think, help us shift our mentality to more of a whole health approach so that we can focus on screening, so that when people go in to see their primary care doctor, it may not be so unheard of to be screened for depression or anxiety or substance abuse problems. That should be part of screening, just like kids get screened for hearing impairment and you get screened for your vision and things like that. It all needs to be incorporated. By doing that, we can certainly identify and intervene earlier and lead to better quality of life and better outcomes. As I mentioned, that report back in 2006, I think really was the shot across the bow nationally, and states and providers were already starting to acknowledge that we must do more around integration. So if you even take the healthcare reform legislation off the table, because there are still some people on polar opposites about what needs to happen and what doesn't need to happen, you can't ignore the fact that integration has already been something that we've recognized, and that train has kind of left the station. Even if healthcare reform were to go away, there is going to continue to be this effort to better integrate care. One of the other potential advantages, and I never like to start out with this because quite frankly the main advantage is about healthy outcomes. People living longer, people being more productive in society, able to continue to work and have meaningful lives. But hey, it also actually is cheaper if you do it right and you intervene early. There is the real potential that we will see some significant cost savings in a healthcare industry that, quite frankly, in this country is unsustainable. So that's another main reason why we want to move in this direction. So the rest of the slides that I want to kind of bring you all up to speed with is the work that's been going on at the Department of Health Services in partnership with our Medicaid agency in Arizona to really look at how we can further integration. And as a state, we made the decision that we want to start first with focusing on adults with serious mental illness. Our belief is that as we really learn from this and we roll this out, I think you will see that there will be a concerted effort to better integrate across the spectrum, whether someone has a behavioral health problem or not. But we figure we're going to start with those that we know we can truly impact probably fairly quickly. So we established some foundational principles, and you can certainly see these for yourselves. One of the key ones really is engaging our stakeholders. We need to have the buy-in from everybody in Arizona that this makes sense and we're all on board and we're going to think creatively and make this a success. We're clearly talking about system transformation, coordination, outcomes, and costs. And I know you can't really appreciate all the different bubbles from where you're sitting, but this is a picture that someone from Access, our Medicaid agency, tried to put together to demonstrate why transformation actually makes sense when you look at where people in our system in Arizona that are using the public system for the most part, how they need to try to navigate. You've got behavioral health through the regional behavioral health authorities in one big bubble. You've got primary care through Medicaid health plans in another bubble. If you're in the long-term care system because of a developmental disability, or if you're an elderly person, you're in a third system. Each of these systems may have their own care coordinators trying to assist you. If you're a Native American, heaven forbid, you might be using Indian Health Services, and then you got to take that into account. If you have Medicare, then you've got a Medicare plan, and it becomes just a nightmare. For us, I can only imagine how it is for somebody who's new to the system or perhaps simultaneously struggling with incapacitating addiction or severe mental illness. So once we kind of saw that, we thought, we should have been talking about this a long time ago. So what we are working on now is, what I see an acronym, REBA. Does everybody know what REBA means? It's our Regional Behavioral Health Authority system, and Arizona is structured so that we have 6 geographic regions that the state is broken into. And interestingly enough, there are still states out there. I was just reading an article yesterday where their public mental health system is all county-based. And there are states that have 99 counties. Could you imagine what that would be like if every county kind of was doing their own thing? So, you know, Arizona at least has this larger regional system that is organized at the state level, so we try to bring some consistency in terms of the services that are provided, the eligibility for those services. And we go out for bid for new contractors every 5 years or so, and we will be going out for contract in this Maricopa County region. In the next year or so, we will put out our request for proposals, and we will open it up for new vendors to come in that think they can improve the system in Maricopa County. So what we are doing now is working very, very hard with the community to get input to draft what this next contract will look like. And it's going to be very, very different based on the information we've already shared. Currently, we have one contractor in Maricopa County, that's Magellan. We are contemplating whether or not, given the size of Maricopa County and the potential benefit of adding more choice, if we'd want to have more than one contractor in Maricopa County. We have not made that decision yet. If you have thoughts on that, let us know. But the big difference that this contract will address is that the Regional Behavioral Health Authority contractor or contractors will be responsible for all physical health care services as well as behavioral health care services for adults with serious mental illness. So instead of giving the funding for physical health care services to separate health plans, that funding will come to the Regional Behavioral Health Authority and all the responsibility that goes with it. They will need to have a network of physical health care providers, specialty providers, hospitals, and they will need to help coordinate the physical health care as well as the behavioral health care for these folks that we just talked about dying 32 years younger than the general population. In addition to that, this Regional Behavioral Health Authority, and this is brand new ground, will also need to become a recognized Medicare provider, because about 50% of the adults with serious mental illness also qualify for Medicare. And that's been like a black box in terms of being able to help manage the care that those individuals are getting, as well as knowing what care they've gotten and what lab work has been done, what medicines have been prescribed. So the Regional Behavioral Health Authority will also then ideally be the Medicare provider for these individuals, which adds a whole new element of being able to coordinate care. Let's see, there will be, and I have a picture that I'll share with you a little bit more about this healthcare team that will be working very closely together. It's a multidisciplinary approach where you'll have physical health care and behavioral health care providers working side by side to make sure that the service plan not only addresses housing needs, employment needs, behavioral health needs, but also physical health care needs. What are the outcomes that we're working for towards this particular individual, and tracking as a team whether you're meeting those outcomes. So for the seriously mentally ill members in this health plan, it will be very, very different. But for the individuals that are receiving behavioral health care services that are not diagnosed with a serious mental illness, it will kind of be business as usual in terms of what the regional behavioral health provider will do. Doesn't mean that's the way it's going to stay forever and ever. We hope we can continue to move towards real health team integrated care for everybody, but we just didn't want to bite off more than we could chew right away. So this is kind of my latest version of my picture. We've kind of evolved it as we've gotten feedback on it, but in the center you'll see this multidisciplinary team, and that's where care coordination will kind of be organized from. That multidisciplinary team may be all in one clinic, it's feasible, or they may be in all kinds of different clinics around the valley. But regardless, the expectations for that care coordination will kind of reside with this team. And that team, as I just mentioned, will be responsible for addressing all of the various needs of these individuals with serious mental illness. And so it's this, what's described as a health home. You've probably heard the term medical home, which primary care physicians have used. The term that's kind of being bantered about now is more of like a whole health home. We don't want to necessarily limit ourselves to just kind of this medical concept, especially in the behavioral health field, because there are many things that are so important to recovering from an addiction or a mental illness that aren't necessarily medical in nature. So we're talking about health homes. But kind of this blue cloud that's supposed to kind of float around over everything that's taking place is where the use of evidence-based practices. So we want all of these different service providers to be implementing evidence-based practices, thinking in terms of whole health and wellness, thinking in terms of chronic disease self-management, helping individuals who have a chronic disease like diabetes really learn what they can do to also keep themselves healthy and prevent further progression of the illness. And then shared medical records, and to the extent that we can really start to leverage health information technology, electronic medical records, and other sorts of data exchange, especially for providers who may be scattered all around the valley. That will be a big part of this. So just to kind of summarize the enormous amount of work and activities that need to take place before this next kind of contract goes out for bid next year, we're talking about a very different model. We're talking about the Department of Health Services, the Division of Behavioral Health Services, getting into the physical health game a little bit, and we got a lot of work to do to prepare ourselves for that, as well as providers in the community. When we're talking about these integrated health homes and the ability to coordinate and think about not only behavioral health services but also physical health services for individuals who may be homeless or individuals who may not have seen a primary care doctor in 30 years, we need to define the services that are going to facilitate this kind of coordination. We need to think about who are the team members that need to be a part of this. One of the advantages that Arizona has, especially when it comes to devising this kind of an approach for the behavioral health community, is we have a very robust framework already in place and an infrastructure for peer support services and family support services. And we know that some of the most effective kind of change agents for changing behavior are people who have lived experience. And so we see a real role for team members to include peers and family members that either have been in the system themselves, are still in the system themselves, or have a family member in this system. And we see the ability for them to really provide a lot of education and support around wellness, nutrition, disease management to be something that we lean on this part of our workforce to do. So we need to identify not only these team members, we need to identify what sorts of best practices we really want to enforce and embed. We need to define, and this is where I think SIRC and you guys can offer some valuable insight for us too. We need to know on the front end what are some of the targeted outcomes we want to track so that we can see what sorts of baseline measures we have, and we can define the methodology for tracking those outcomes over time, both at the individual client level as well as at the larger system level and community level. And then we need to do a whole lot of work. Oh, she's making eyes over there. She's the wheels are turning. I love it. And then we also need to be obviously establishing our expectations around the information technology and the sharing of information across providers. There's a lot of work going on behind the scenes right now around data analysis, and really, especially in Maricopa County, because we need to be able to establish new funding mechanisms and stuff for this population. So we need to know as much as we can about this defined population in Maricopa County. And so we are analyzing the last, I think, 3 years worth of claims information for medical services, as well as claims information for behavioral health services. We're trying to get as much information as we can about Medicare costs and services that have been provided. We're looking at the types of services and the frequency that those services have been provided. And we're looking at the diagnostics, meaning what sorts of behavioral health diagnoses and physical health diagnoses does this population in Maricopa County have, so that we can kind of stratify and get the best sense of what anticipated services we're going to need, what kind of network we're going to need, and what kind of outcomes we really want to best track. So that's still going on, and an enormous amount of data will be made available when the contract goes out for bid, because any potential bidder is going to want to also access all of that information and profile and draw some conclusions. We're working with St. Luke's Health Initiative actually to help with stakeholder input, both from the peer and family community as well as the provider community. So that's going on. We are also working with the Center for Medicare and Medicaid Services, as well as SAMHSA, the Substance Abuse and Mental Health Services Administration, to get guidance from them and technical assistance. So we've got, in the next 12 months, again, about this time next year, it has to be on the street. We really want to give ourselves plenty of time not only to evaluate the bids that come in, but we want to make sure that we have as much time as possible after we announce the awards for the Maricopa County contract, so the winning bidder or bidders has plenty of time to smoothly transition. Again, we're talking about the most vulnerable population perhaps that we serve in the Department of Health Services, one of the most vulnerable, and it's imperative that we not have people fall through the cracks, all of a sudden be confused about where they go and what's available. So we want to make sure we have plenty of lead time. So we will be getting this request for proposal out by this time next year. We will also be working with our Medicaid agency to write and submit an amendment to our Medicaid state plan that describes our health home integration initiatives. There is, through the healthcare reform legislation, an opportunity for us to get a significantly higher federal funding contribution for this project after we get it in place. But we have to time this very carefully, because the way it's written is the federal government will increase the percentage of the funding that they give to the state for the health home activities for only, I think, 2 years. And as soon as they approve the amendment, the clock starts ticking. So we want to make sure we've got everybody trained and everybody's clear on what to do, so we could maximize that. We're going to need to modify a bunch of our policies to incorporate physical health care expectations and all of the health home coordination. We need to establish new reimbursement rates, etc. We need to address confidentiality and HIPAA concerns, because we are going to be expecting a significant increase in the sharing of information but we also need to be respectful of certain limitations related to HIV/AIDS, substance abuse, and things like that. So we're working with that. We need to address all of our workforce needs, including the training that may be needed. And we are also working with our licensing area at the Department of Health Services, because we know right now our licensing rules are an obstacle to trying to have people in the same building that are providing behavioral health services and physical health care services. There are some very, very goofy rules right now that you can't share hallways or you can't share waiting rooms and things that make no sense. And so we've got permission to go in and really revise those, which is incredibly exciting. Just a couple other things, and you guys have not asked a single question, but I don't think I've really come up for air. So we're going to wrap up quickly, and then we'll really, I want you guys to ask questions. But again, throughout the process, and one of the very exciting things about this process is that the Regional Behavioral Health Authority is still going to be a contract with the Department of Health Services, Division of Behavioral Health Services. We've heard a lot of concerns from peers and family members, as well as the behavioral health community, that if you start taking on physical health care, are you going to inadvertently start to lose the emphasis and the focus on behavioral health? And we want to make sure that that does not happen, because there is an incredible amount of energy and research that demonstrates that recovery can happen. It absolutely must be our goal. It's not about keeping people out of a behavioral health crisis. It's about helping them really obtain the quality of life that they want and contribute to their community. And so we come from a very different perspective. It's why Arizona, I think, has carved out behavioral health care from some of the medical care. And so we must preserve our recovery emphasis as we move forward with this. We are continuing to not only include but strengthen peers and family involvement and participation really at all levels of this process. And we're trying to be as transparent with the entire community as we can. And so I've got just the website link on our main Department of Health Services website, and you'll see that little icon if you go to the website, and you can click on that, and it'll take you to another page on our website where we've got kind of a whole bunch of stuff related to integration, but I wanted to just highlight two particular sites. One is if you clicked on the specialty REBA. That's what we've been talking about in terms of this next contract. Although I'll give you a heads up, we're maybe starting to kind of move away from this term specialty, because it's, I think, actually made it more confusing for folks, and we don't want individuals with serious mental illness to somehow feel that it's special in a bad way or they're being segregated. And we also don't want the community to think that we've got a REBA over here and then we've got a separate specialty REBA, because it's really one and the same. So while it says specialty REBA today, it may move back to something like Maricopa County REBA contract or something, I don't know. And then the other arrow is the contact us. And I'd encourage you, if you have a random question, a random thought, you can go in. Any advice you have for us, we are definitely interested in hearing it. This is some uncharted territory. I will share that nationally, I think many other states are watching what's going on as we kind of work our way through this process. Other states are very interested because, again, that report, they know individuals are not getting the physical health care that they need. So if you clicked on the specialty REBA link, it then takes you to more information where we're trying to keep all the updated resources around this contract development and this work. And again, you can contact us from there as well. I think that's my last slide. So, okay, so